Okay, now that we've reached the diagnostic data section of our case history, we have to answer ourselves what diagnostic methods should we choose among this very wide uh, probability of methods available. Well, before answering that, I want you to be aware of this specific methodological principle in logics and philosophy, which you might know. It's called the Occam's razor. So, this is a principle which states that entities, it means some ideas or some things or some evidence. So, entities should not be multiplied without necessity. Or, if we paraphrase this statement, mm, it says that when presented with competing hypotheses, so in our case, the competed hypotheses are those diagnoses we've previously discussed in differential diagnosis section. So we are aware that our patient has acute appendicitis, but still we're not definitely sure that all other diseases with similar symptoms can be excluded. So we now have competing hypotheses. So when presented with competing hypotheses that make the same predictions, it means in our case that while having similar symptoms obtained from physical examination and anamnestic collection, we still believe that they can be signs of some different diseases, not exactly acute appendicitis. So, when presented with competing hypotheses that make the same prediction, one should select the solution with the fewest assumptions. And it is not meant to be a way of choosing between hypotheses that make different predictions. So, in our case, it means that if we are not definitely sure which disease exactly is present in our patient, we should choose such a diagnostic method, the solution to find out the correct answer. So our diagnostic method must be chosen to be most simplest, most rapid, and most specific to clearly distinguish between those diseases. For example, if it is enough to perform a simple X-ray to diagnose the fracture of some bone of the forearm, if X-ray is enough, we won't do a CT scan because it will give us excessive information we won't need. All information needed for differentiation between fracture and non-fracture can be obtained by a simple X-ray, and our treatment strategy will also be based only on this data. We don't need some additional data. We don't need to multiply entities. So we are not choosing between hypotheses that make a different prediction. We are just looking for the most simple method which will be able to distinguish one disease from a group of another. So if we return to our diagnostic section, we need some diagnostic tools to differentiate between those diseases we've discussed previously and maybe some other diseases which were not mentioned in our differential diagnostic session, but it doesn't mean that they are definitely absent in our patient. You know, anything may happen. That's medicine. That's a living human. It has a lot of possibilities. So, uh, if we think that our patient has specifically acute appendicitis, it means that we need to choose such a diagnostic procedure which will give us an opportunity to see pathologic appendix, the diagnostic method which will show us the status of other abdominal organs, and diagnostic procedure which will give us information about like the systemic status of this patient. Either he has a local inflammatory response, or is his inflammatory response became systemic already. Now, in your guide there is a number of methods which is used to investigate the diabetes mellitus, so we take them away. It says in your manual that since preliminary diagnosis is established, the plan of additional investigations should be worked out. It consists of analytic methods known to be useful for accurate definition of disease, and you have an example. So let's return now to our section with preliminary diagnosis. First thing that comes to our mind, the most prominent symptom which gives us the basis to suspect that there is acute appendicitis, it's these abdominal symptomatics. So we see clearly that this patient has muscular defense, he has pain in his abdomen and in a specific region of his abdomen. This pain increases during deep palpation. This patient has positive symptoms of peritoneal irritation. Beside that, he has an increased temperature. Also, we've noticed that he had loosened stool with liquid consistence. He has frequent urination, and if this is a female patient, we notice that the pain increases during bimanual examination. So first thing we need among our diagnostic tools, we need some overview of what's happening inside the abdomen. And since we're talking about a method to overview something, we search for a visualization method, and that is why we think that it's going to be some radiological method. So among radiological method we have, as you know, X-ray, CT, MRI, PET-CT, other more advanced techniques, but we are searching for a method which is most simple, which requires the most simple to handle equipment, method which is not invasive, which doesn't cause pain, method which is fastest to perform, method which is relatively cheap. It doesn't include some very expensive drugs or contrast or something. So this method, all these characteristics fit well for abdominal ultrasound. Really, this is one of the most technically simple methods of radiological investigation, first. Second, it gives us a very quick overview of all abdominal and pelvic organs. It's quite fast to perform. It's not invasive. It doesn't require a specific place or specific patient's preparation, and it's just easy to perform. So first thing which we are going to add to our instrumental methods, that's gonna be abdominal ultrasound. So why are we using this method? We use it to get a quick and feasible overview of abdominal and pelvic organs. And if we are lucky and the appendicitis is on the stage of quite developed disease, we're able to see the inflamed appendix. And if we succeed in that, if our ultrasound radiologist will show us a picture like, look, there is an inflamed appendix, its wall is thickened, it is swollen, it has periappendicular edema, and around this inflamed appendix there is a slight amount of inflammatory effusion, then we can be sure that this patient really has acute appendicitis, because we see it on the screen of the ultrasound monitor. But if we see that, can we be sure that that's all that he has? Well, technically no. If we see that he has appendicitis, we can't be sure that he doesn't have any other abdominal pathology or pelvic pathology, as we've previously discussed. So let's take a quick overview how what information can be obtained from abdominal ultrasound regarding all those diseases we've mentioned in the differential diagnostic session. So, in case of acute pancreatitis, we can see the enlarged pancreas, we can see the edema of pancreatic gland, and we can see some effusion around the mesentery or the mesocolon. In cases of hollow organ perforation, we will see an excessive amount of free fluid, which is collected mostly in the lowest parts of the abdomen if the patient is lying on his back, that is the pelvis, the space between diaphragm and the liver, in left subdiaphragmatic space also, and on the flanks. Also, we'll see that intestinal loops are like swimming in a liquid. So if we see that and we compare it with patients' objective findings and anamnesis, we also can be quite sure that he has this disease. Acute GI bleeding. Well, ultrasound can show us that the patient's bowels are filled with extra amount of some fluid, but we can't be sure if it's blood or some other fluid. So if we differentiate acute GI bleeding, which is intraluminal, ultrasound won't help us a lot. Acute cholecystitis, during ultrasound examination you will see also the thickened wall of the gallbladder. You may see also gallstones. You may see the cystic edema which spreads to the surface of the liver, and you may see also the effusion located in right hypochondric region, for example. But changes in gallbladder are quite well seen on abdominal ultrasound. In cases of acute bowel obstruction, what you will see on abdominal ultrasound, it will be dilated bowels with very low weak peristalsis, and if you are lucky and you will be able to see the point where the obstruction is present, you may see like the pendulum. You may see that the peristaltic wave approaches the block, it can't pass this block, and then there is a wave of anti-peristalsis. In ultrasound it's very clearly seen. If you imagine that this is a fluid which runs inside the dilated bowel, the wave of peristalsis brings it towards the block, it can't pass, and then it moves away, and then once again it tries, it doesn't pass through, then it comes back, and you can see it for multiple times. That's so-called the pendulum sign. That's what you can see during abdominal ultrasound in cases of acute bowel obstruction. For acute mesenteric ischemia, ultrasound won't help you a lot. If you have an extremely experienced radiologist and your ultrasound machine is able to perform the energy Doppler or just ultrasound with Doppler scanning, you may see that the blood flow in the superior mesenteric artery or superior mesenteric vein is absent. You may see it by color, the exact level where the blood flow breaks. The break of color will be the point where there is a clot or something else inside a large vessel, but that doesn't work each and every time. That's once in a while. So during incarcerated hernia, first you can be able to visualize the hernia sac. You may place your ultrasound transducer on the hernia sac, and if you move it properly, if you find this very precise view which provides you a good picture, you will see that there is a bowel inside this hernia sac. It's not peristaltic, and there is a liquid collection around this bowel. That will give you a very clear sign that this patient might have incarcerated hernia. In cases of ovarian cyst perforation, together with other gynecological findings, for example ectopic pregnancy, as we've discussed previously, combination of abdominal ultrasound plus transvaginal ultrasound will give you the whole picture of vagina, uterus, cervix, both fallopian tubes and both ovaries. If your gynecologist or radiologist who performs gynecological ultrasound is quite experienced, he will be able to show you all that. You will have all your necessary information about the patient's gynecological status. Same goes for urological disease. It's quite uh, simple and relative and very relative to perform the ultrasound of kidneys. It's practically always possible to see the calyces of both kidneys. It's possible to visualize what's inside the urinary bladder, if there is retention urine, if there are stones inside the urinary bladder, or in cases if it is cystitis. It's possible to measure the thickness of urinary bladder wall. It's possible, even if you have a good ultrasound machine, it's possible to see the status of the mucosa of the urinary bladder. You may see that it's swollen, which gives you information that there might be an inflammation present in there. And once again, you will receive a very good information about both urological status and gynecological status. So abdominal ultrasound can be a very effective and useful tool to assess patient's status of his abdominal and pelvic cavity. But this is not enough. For example, when we've talked about gastrointestinal bleeding, which occurs intraluminally when the blood pours out inside the intestinal lumen but not inside the abdominal cavity, it may be very hard or maybe impossible in some cases to provide clinical diagnosis where exactly is the site of bleeding. So by clinical signs, you may predict that this is either upper GI or lower GI. So in cases if you'll see that the patient has clinical signs of hemorrhagic shock, for example, if you'll see that his body temperature is lowered, his skin is pale, his conscience is somehow unclear, his mucosas are pale, he has tachycardia, tachypnoea, his systemic blood pressure got low, and his urinary output is low without compromising the urination process, you might catch yourself that this patient has a hemorrhagic shock. And for example, if you'll know from his anamnestic data that he had vomit with scarlet red blood, or if you've performed digital rectal examination and you find melena on the tip of your glove finger, you may suggest that maybe the source of this GI bleeding is somewhere in the stomach or at the duodenum, because this is a site for peptic ulcer formation. So if you see this combination, find out if he where is the source of this upper GI bleeding, you will have to administer upper GI endoscopy. or in other words, esophagogastroduodenoscopy. But in cases if you will see signs of clinical shock and scarlet red blood mixed with patient's stool, or in some severe cases even defecation with blood, in this case you probably won't need upper GI endoscopy, but you'll need the lower GI endoscopy, which is colonoscopy. Performed, of course, after bowel preparation. In this case, the endoscopist will tell you that, for example, you know the source of his bleeding is a tumor which is located in sigmoid colon, or what's bleeding is an area of inflammatory bowel disease, which is somewhere either in a transverse colon or in ascending colon or whatever. That's another question not relevant to our topic. Next, if we think that patient has signs of acute mesenteric ischemia, we see something familiar on a Doppler enhanced ultrasound examination, and we need to know if he is a candidate for revascularization, for vascular surgery procedure which will restore his blood flow in the mesenteric vessels. If we need to know precisely where exactly is level of blockage, we need to perform either angiography or, if it's possible, a CT angiography. In order to obtain precise information of a vascular block among mesenteric vessels, if you see that your patient does not have signs of acute mesenteric ischemia or either GI bleeding, I think you won't perform him angiography just routinely, just to do some examination. This is an invasive procedure which has complications occurring, and that's not gonna be very safe. So in most cases, abdominal ultrasound, it can be enough. But if your abdominal ultrasound can't give you some definite information, or if abdominal ultrasound is of low quality, or if it is not available, or in cases when you diagnose that the patient just has a diffuse peritonitis, if he is in a state of intoxication and you can't find the exact source and you can't evaluate exactly the spread of peritonitis inside his abdominal cavity, then what you will need definitely is a CT scan. CT scan with contrast enhancement. Maybe this patient he has appendicitis and his appendicitis is in such a complicated state that he already presented with perforation of the appendix. The appendix is completely destroyed, and that is why ultrasound won't see it. And because he has a bowel perforation on the place where earlier his appendix was, but now he has a diffuse fecal peritonitis. You need to verify this information. You need to see what is the spread of this peritonitis, what organs are involved, or maybe there is some another source of peritonitis, for example perforation of large intestine tumor, or it may be a complicated case of gastric cancer or any other reason which causes peritonitis, or patient had previously acute bowel obstruction and the dilated part of the colon it got perforated, and you will now have a combination of diffuse peritonitis and acute bowel obstruction. That's an extremely poor case, and you better be aware of that before surgery, not during surgery, because uh, you might have very big problems with this patient. So a CT scan with contrast enhancement can give you maybe the most precise overview information about what's happening in the patient's abdomen, but according to this principle we've discussed, that you don't have to multiply entities. You use CT scan in cases when other radiologic methods like, as previously discussed, abdominal ultrasound or abdominal X-ray are not sufficient to make a clear diagnosis. So this is when you switch to CT scan with contrast enhancement. A couple of words about abdominal X-ray. It must be mentioned after abdominal ultrasound. Abdominal X-ray might be an extremely valuable diagnostic method if you suspect perforation of a hollow organ in this case, you will see a free gas inside the abdominal cavity. As you know, during conventional simple X-ray exam, tissue organs are uh, shown as white structures, while cavities filled with gas or just filled with nothing, they are black, and liquids are white. So in cases, if you will see a strip of black, which refers to air, if you see a strip of air between a patient's diaphragm, which of course has a tissue thickness and is shown as white on X-ray, and intestines, which are also of tissue thickness and also are mostly white. So if you see this black stripe between diaphragm and other abdominal organs, you can be definitely sure that is a free gas inside the abdominal cavity, and it got there from somewhere, from a hollow organ, either from perforated stomach or from perforated duodenum. That is going to be one very valuable and very easy to match diagnostic sign, which will give you opportunity to switch to surgery, because perforation of a hollow organ, that's definitely an indication to perform surgery for this patient. Another valuable thing that can be given to you by X-ray in cases of acute bowel obstruction you may see the bowel arches. Similar to a gas inside the free abdominal cavity, when bowels are extensively filled with content, the intestinal content stops because peristalsis stops because of intestinal block. This content starts to rot inside there, which leads to extensive production of gas. Gas goes up, it separates from the liquid part of the intestinal content. Gas dilatates the bowel in a very specific way, and you can see it on X-ray as a black arch. And those black arches, they are situated in a very specific manner, like a cascade up and down. So if you see that on abdominal X-ray, this is also a very comprehensive and very clear sign that this patient has severe bowel obstruction. And this may also give you and all arguments to proceed to surgery in this patient. But, as we've previously mentioned, if these two radiologic methods, or one or another, or their combination, are not enough for you, if you can't make a clear statement out of this diagnostic data, then it gives you a right to switch to a CT scan. So that's it for the abdominal, abdominal parts of the diagnostic procedure. Next, what we obviously need to perform to this patient, we need to examine his chest. And for chest examination, we definitely need to perform him an X-ray. You might ask, why should we perform chest X-ray for a surgical patient? Well, reason number one. This patient Probably, if he's surgical patient, he will require some abdominal surgical procedure, and this patient will have to go to general anesthesia. If he will be administered with general anesthesia, it means that he will have artificial lung ventilation. And that's why it is important to know that he doesn't have any lung pathology, some pneumonia or tuberculosis or pneumothorax or pleuritis or abdominal lung atelectasis or chronic obstructive lung disease. This is very important to maintain his lung ventilation during surgery and maintain artificial lung ventilation. Next, it can give you an overview information about tuberculosis. In modern world, you know that we have now an epidemics of COVID-related pneumonia, so a simple X-ray can give you a brief information if the patient has some lung pathology, which can make you aware that you better test him for COVID. And finally, if, for example, this patient he had some chest traumas, this also might have consequences of his breathing, for example, pneumothorax or perforation of pleural cavity, and you can be also aware of that. Finally, it's not so very frequent case, but still sometimes pneumonia, which is located in the lower lobes of lungs, it may spread. The inflammatory process may spread through parietal pleura, and it may spread through diaphragm inside the abdominal cavity. This inflammatory process may irritate the parietal peritoneum of upper abdomen, and it might cause a very specific clinical condition when patient might have pain in his upper abdomen. So briefly, these are 5 most frequent and most relevant indications why should you perform a chest ray to each and every surgical patient. You might ask, but what about a CT scan? If, for example, we already administer an abdominal CT scan to this patient, why can't we perform him a chest CT scan? Yes, it could be, of course, quite valuable. It could produce you additional diagnostic information, but if we are talking about these diseases which create the acute abdomen, in absolute majority of cases, chest CT will show you nothing very specific, nothing relevant to your treatment strategy. This will only prolong time for diagnostic event. And if it prolongs time of diagnostics, that creates a delay from diagnostic to treatment. And if the patient you're dealing with, he has signs of peritonitis, his time is very valuable. The longer you will keep him without treatment, the worse his prognosis will be. So if patient's condition is severe, don't use time-consuming methods. Do something which will give you maximum information for minimum time. So I think that's go. Oh no, not enough. Another investigation which also has to be performed to every patient who is about to undergo surgery under general anesthesia, that is electrocardiography. Why ECG? Well, as similar to chest X-ray, reason number one, the patient will undergo general anesthesia. Knowing the patient's heart parameters is very important for an anesthesiologist and doctors in the intensive care unit to properly maintain his general narcosis. For example, if he has arrhythmia, he is going to receive some specific treatment to normalize his cardiac rhythm during the operation, and after operation, when he will be in the intensive care unit, anesthesiologists and intensive care doctors will be able to uh, evaluate if his cardiac treatment works. They will compare it with baseline ACG and they will know if their treatment strategy works fine. So you need that for baseline. Now we proceed to laboratory analysis, and first one among them it's going to be as it's mentioned in your guide, it's going to be the complete blood analysis. So, as it says in the manual, complete blood analysis, or in other words, it's called the general blood analysis, will give you information about the rates of hemoglobin in this patient. This is a very crucial finding when you evaluate the stage of hemorrhagic shock, or if you are about to evaluate the blood loss in patients with gastrointestinal bleeding. Signs which will give you additional information in evaluating blood loss, that's the red blood cell count, mean corpuscular volume, mean corpuscular hemoglobin, erythrocyte sedimentation rate. That's quite an old parameter, it's not mostly used in nowadays, so we won't stop at that. Next, white blood cells level. As you know from your pathophysiology classes, white blood cells are the main affecting cells during inflammation. So if you suspect that this patient has a systemic inflammatory disease like peritonitis, then you will expect that his level of white blood cells will be elevated. But it's not going to be just a specific, just an overall elevation. You will see an increased number of stab neutrophils. These are young forms of neutrophils which are overproduced by organism very rapidly as a rapid response to acute inflammation, and you're gonna see that if the patient has this condition. Next, other types of white blood cells are also very important. It may give you additional information about severity of stomach inflammation syndrome. And finally, platelets count. Platelets count give you very important information about patient's state of coagulation. For example, if the patient has an extremely low number of platelets in his venous blood, you may be aware that his coagulation system is not working well. So you have to administer him some extra drugs which will increase his coagulation potential, so you could effectively treat GI bleeding, and of course you don't want to have the recurrence of GI bleeding after surgical treatment. That's why platelets and coagulation system analysis is also very important. So in urine analysis, what you want to know in cases if you diagnose acute cystitis or other urological infectious diseases, you need to see what about white blood cells in the urine. For example, if you will see in the patient's analysis that white blood cells cover the entire field of view, that's definitely a sign of acute inflammation of either urinary bladder or kidneys. If you see epithelial casts or hyaline casts or some other casts, this is a sign that this patient has some kidney damage, so you'll have to pay more attention to diagnosis of kidney level. If patient loses protein with urine, that's also a very crucial symptom of renal injury. You'll have to pay more attention there. Presence of glucose in the urine, it's a symptom of severe diabetes mellitus, which requires insulin therapy. Acetone is also a sign of diabetes mellitus. It means that you're gonna perform a more extended diagnosis of his endocrine status for diabetes mellitus. Clinical chemistry reflects the functioning of the liver. As you can see, these are most of enzymes which show the information about liver functioning. You will learn more about what those are liver enzymes. You will learn about what they are needed for in specific course of internal medicine. So bilirubin shows you the information how the bile gets out of the liver. If, for example, there is a cholestasis, for example, when the stone from a gallbladder blocks the common bile duct, patient's bile isn't available to come out of the liver. In this case, you will see that his direct bilirubin will increase, for example, which will also provide you valuable information. Amylase level, it's a very specific indicator of pancreatitis, because amylase, that's a pancreatic enzyme. Normally amylase gets inside the GI system. It gets intraluminally to process glucose and polysaccharides in our intestine. but in cases when there is a damage of pancreatic tissue, in cases of peritonitis, this amylase gets inside the circulation instead of in intestinal lumen, and you will see that the level of this amylase is increased. Same goes for lipase, but lipase is used less frequently. The main parameter is amylase. Total protein, it's a general indicator of patient's nutritional status. If you see that his general protein level is lower than average, it means that he has some hypercatabolic process. Either it's a very severe inflammatory process, or in most cases it's a sign of a malignancy. Glucose level on fasting, it's a brief indicator of if this patient has or if he has now diabetes mellitus. Level of serum insulin usually isn't measured, it's not very relevant in clinical medicine. C-reactive protein, or CRP, that's an extremely valuable parameter if you suspect acute inflammatory process, either peritonitis or some inflammatory process inside the abdomen, or acute appendicitis, or cholecystitis. If this parameter is increased, you can be definitely sure that this patient has developed already the acute inflammation. Hemoglobin 1C, A1C, that's an indicating parameter for primary diabetes mellitus. Serum lactate and electrolytes are very important to know the patient's status of infusion, if he needs infusion of colloids or crystalloids. Urea, nitrogen, and creatinine are indicating signs of renal function. So total oxygen, cholesterol, triglycerides are not so important in surgical clinic, same as blood pH, concentration of oxygen, carbon dioxide. In surgical clinic, if this is not a critically sick patient, that's not very important. So you want this part in here, all this. You may not use that in your academic case history, because that's related to some other diseases. Same goes for hemoglobin A1C, insulin. This is a draft for diabetes mellitus case history, so that's not what you really need in surgery. Let's, for example, let's see what's also written in here. Stool analysis. Do we need to know that? Well, definitely no. If we do not suspect that this patient has some intestinal infection, it may be so, because there are certain intestinal infectious diseases which can mimic acute abdomen syndrome. So if we will be aware that this patient might have either salmonellosis or escherichiosis or cholera or some other intestinal infectious diseases, we will definitely need to check his stool for those microorganisms which cause these diseases, but that's not what surgeons do. So in our case history, we won't need that. So chest X-ray, ECG, we've discussed that. Abdominal ultrasound, yes, we've discussed that. So this might be the end of investigation criteria section. Once again, let's Once again, let us summarize. Let's summarize what can we obtain from diagnostic section, the additional diagnostic tools. Abdominal ultrasound will give us a quick and feasible overview of abdominal and pelvic organs. It's better to combine conventional abdominal ultrasound with gynecological transvaginal ultrasound. Abdominal X-ray may give us signs of hollow organ perforation or acute bowel obstruction. Upper lower GI endoscopy will provide us information about presence of intestinal bleeding and the source of bleeding. Angiography or CT angiography will show us the exact point of vessel block in cases of acute mesenteric ischemia. CT scan with contrast enhancement might be used in cases when previous methods present insufficient information, or you see that's not enough for your decision making. Chest X-ray gives us, together with ECG, gives us information about which will help in performing and maintaining general anesthesia with vital support. Complete blood analysis will show us signs of anemia, the drop of hemoglobin, increase of white blood cells and specific subpopulation of white blood cells in cases of acute inflammation, together with C-reactive protein. Urine analysis will give us opportunity to differentiate primary urological diseases from abdominal surgical diseases which involve urinary system in a secondary manner. And clinical chemistry will provide us information about liver functioning. It will give us information about pancreatic amylase, which will give us indications if this patient has or he has no acute pancreatitis. And in most of the cases, this additional diagnostic methods are enough to give some discrimination about each of these diseases which correspond to acute abdomen syndrome. Also, all these methods will cover gynecological and urological diseases which we are differentiating with acute appendicitis. So this might be the enough diagnostic algorithm. What you need to do in your case history, you will need to describe in detail all this by yourselves. So when you are talking about each of these diagnostic methods, you write down what is the indication, second, what diagnostic information you are expecting, third, what are normal ranges, for example, for blood analysis, normal ranges are written in your manual. So what I want you to do, you draw a table if we're talking about blood analysis. In column 1 you write down the analyte what exactly are you about to investigate. In column 2 you write reference values. In column 3 you write the actual value, actual patient's value, and I've mistaken a bit, you'll need to do it in 4 columns. In column 4 you'll have to write briefly interpretation. You have to write what it means. For example, let me show you on hemoglobin. You write hemoglobin, then you write reference values. This is the reference value for males. Then in cases of, for example, if we are talking about acute GI bleeding, here you write, for example, 90 grams per liter. That's below reference value. It means that this patient, or this is a sign of an acute GI bleeding regarding clinical data and upper GI endoscopy data. If the range is normal, you can just leave this field blank. For example, if we're talking about total bilirubin, actual patient's bilirubin in case of acute appendicitis will be absolutely normal. Let it be 12 micromole per liter. That refers as normal range. Here you write down that it's normal range. No additional comments. It's okay. That's normal. And I want you to do the same for these methods. For abdominal ultrasound, let me show you on an example of abdominal X-ray. In here, instead of reference values, you will just have to quickly describe what should be the normal picture of abdominal X-ray. For example, no free gas, slight amount of gas inside intestines, and the actual patient's value field, you'll have to write something which is pathological. If you don't see nothing pathological in your patient, you can just switch to normal, and here you leave like normal range. But if you identify pathology, you must describe what exactly you see pathological on his abdominal x-ray. For example, you see multiple bowel arches. And in the interpretation field, you notice that this is a radiological sign of acute bowel obstruction. So that's what you do for instrumental, for radiological methods, and here is what you do for laboratory methods. And finally, number 4, after you describe normal ranges, pathology, you write a brief summary what is the overall interpretation of all additionally obtained diagnostic data. A brief example may be like this. For example, you write down which methods you've used, and then you say that data suggests that this patient has acute appendicitis because we've identified an involved appendix with thickened wall and periappendiceal infiltration on abdominal ultrasound. Blood count data suggests that the patient has signs of systemic inflammatory response syndrome, and also brief description: increased white blood cell rate, increased C-reactive protein rate, and quite enough. Next, after you've completed the diagnostic data section the way I've described it for you, you proceed to the field of final clinical diagnosis.